Okay, I'm Dr. Alice Finari, and I've been running Journal Club ever since Dean Smith, who's the emeritus dean, said to me, Dr. Finari, we need a medical education journal club. Nobody ever reads the literature on MedEd, and you must do this. And I said, nobody's going to come into a room, Larry, and this is way before the pandemic. So using AI, using virtual journal club was like innovative. It's not innovative anymore, but it was innovative at the time. And it was a way to gather people across 13 hospitals. And now we have 30. And I want to congratulate Beth West for being here as a Nuvance representative and maybe a few other people also. And Nuvance Northwell, let's say, until we do the official. And it's really important that we gather to understand medical education. And I really congratulate Teresa Lazar for picking this topic of coaching and considering that I'm at the Columbia Coaching Conference this week. It's very exciting for me to be discussing this article and having Teresa present. Teresa is a medical educator. She completed her master's in medical and health professions education with me at Hofstra when I was running that program. So I was so thrilled when I met her immediately. I said, you really should get a master's in health professions education, considering who you want to be in your career. And she's a great student because she listened and she right away jumped on the opportunity and did that. And it was such a pleasure. I also mentored her on her final paper. So really great. She is an OBGYN and she is in charge of the advanced clinical experience, which is our third year clinical experience in OBGYN. And she's accomplished to make it a happy, and I put happy, rotation where we have had growing pains and people are happy now in that rotation. So I congratulate her. So she must be doing some coaching if that's happening. I have Dr. Menzin joining me, who is one of the first colleagues I met when I came to Northwell. And we both got certified as coaches, I think in 2023, I think. Dr. Menzin and I both have a strong interest in coaching and are actually running an external coaching program for the Harvard Macy Institute. So I asked Dr. Menzin to come as the discussant today. So we have a lot of good people and all the people online, there's going to be questions. And when the questions pop up, that's an opportunity to participate. And so it's an interactive journal club. And I just want to mention that my students that are on here as part of the medical student as teacher elective, or scholarly concentration, which I started, and my colleague Caitlin Duffy is now running with Dominic Acquista as a partner. I thank you for having the students here, and your voice on coaching and what you think about this is really important for the next generation of residents as MS4s. And I hope maybe when you go on interviews, you might even say to your interviewee or the program director, so do you have any coaching program within the residency? And you could ask that question and they might go, wow, how do they know about coaching? And you could sound really inquisitive and curious, which is always good in interviews, to be curious. So I'm going to let Teresa start because we have a whole presentation here. And go ahead, Teresa, you're on. And Dr. Menzin will be our discussant as the questions arise.
Dr. Finari, thank you so much for the transformative Masters in Education and Health Professions and for the opportunity to speak today. And thank you all for taking the time to join our MedEd Journal Club. And we are fortunate to have Dr. Menzin join us as our discussant today. Thank you, Annie. So we will be discussing the article, Evaluating the Impact of Coaching Through a Transition to Residency, published this year in the Journal of General Internal Medicine, written by Dr. Winkle and et al. Oh, my slides are not advancing. Oh, there we go. No disclosures. Learning objectives. After this session, learners will be able to define coaching specific to transition to residency for junior residents, identify the residents' perceptions of coaching during transition to residency, and describe outcomes of coaching efforts with junior residents. Oh, I'm sorry, there's a delay with the slides. Here we go. Our opening discussion question. Is there anyone among us here today who has had an experience being coached or being a coachee? If you could please share. It's open discussion. Well, I could say for this presentation, Andy and Alice coached me. We'll go over some of the specifics of coaching, and I felt very supported being here and being able to share this experience with all of you today. But coaching is somewhat of a new concept, or it's gaining traction, but you may have heard of mentorship more commonly or sponsorship. Andy, do you care to share any of your experiences as a coach or your thoughts about this topic?
Sure, and perhaps we could just advance that slide.
Yeah.
Seems like a little delay, but and thanks Terry and Alice. And as Alice said, we've been colleagues and partners for a long time. And in fact, even before I understood coaching well, Alice was an informal coach of mine. But we encounter advising, we encounter mentorship. Those are things we're very familiar with. People who we seek out or are assigned to us for guidance and support in various domains of our experience. Uh, and certainly we're familiar with them. Sponsorship is aligned with that. People who advocate for us in other settings, help us along the way, in some way shepherd us to those new opportunities when possible. But coaching is really something very different and often misunderstood. People think of coaching like a sports coach or something like that. It's different. It's a thought partner. It's as opposed to advising and mentorship, which are somewhat asymmetrical and hierarchical, based on experience, knowledge. Coaching is a level playing field. It's a journey together. Certainly the coach brings experience, but that's really a critical thing. We like to say that the client does all the work. Why? Because the client drives the agenda. The client is engaged in self-exploration. The client that plans their growth. The coach helps along the way. And I think that is the essential thing about coaching that differentiates it from advising, mentorship, and sponsorship. I'll stop there.
Okay, thank you, Andy. And I don't know if someone can mute. There's some background conversations that we hear. I'm going to go over mentorship first. As Andy mentioned, it's an alliance, it's a relationship, it's a conversation, it's a check-in. Oftentimes, as a mentor, you listen, you share your wisdom from your experiences, you help with some sense of direction, support, collaboration. It's very much a discussion and can be very long-term. There's some longevity to it. And sponsorship, it's when a mentor or sponsor identifies opportunities, recognizes the learner's strengths, encourages opportunity seeking, offers support as they seek these opportunities, optimizes the candidacy for advancement, nominates a candidate, and promises support. So it's very much driven in some sense or supported by the sponsor for specific opportunities. And coaching, as Andy mentioned, it's very involved with both the coach and the coachee, clarifying, advising, providing resources, performing critical appraisals, giving that feedback in order for the learner to advance, a lot of reflection on the learner's part, and providing a scaffold in order to advance the skills, the learning skills and development and mastery. So if you could see here, the mentorship is conversation, sponsorship is those opportunities to advance, and the coaching is really much step-by-step skilled feedback and advancement. Alice, would you like to add anything?
No, I just want to say that it's very important to understand the difference, because some people just put this into like a word soup, I guess, like a vegetable soup pot, and they just say, okay, I'm doing it all, or they're doing mentorship, and they say, so there are three distinct roles here, and the role that's not here that you will experience as learners especially is advising, and that's a very evaluative role. And that person who's evaluating you crosses a line sometimes into roles that are not so appropriate, like mentorship, because evaluation already implies that they're determining something about your future in a very strong way. So we just have to be careful with these terms. Go ahead, Teresa.
I do want to mention for mentors, you can have more than one mentor,
Yes.
more than one sponsor. And coaching, I think it's dependent on what skills you want to develop, but it is also a long-term type of relationship or specific to the learning needs that you have. But in the terms of residency, hopefully it's more long-term and an investment in your career. So educational coaching, it implements questioning and active listening. It's very goal-oriented with self-directed learning, self-awareness of the learner, and personal responsibility. And skill developments, particularly for this article, are lifelong learning, professional identity formation, wellness, and resilience. All important skills for residency and for life, a lifelong career. So some studies have been done to evaluate coaching outcomes among medical students in general, and it's been shown to increase adaptability, increase receptivity to feedback, all important for learning. There have been some studies regarding physicians training different levels and physicians in practice, and it's been shown to decrease burnout, increase emotional well-being, professional fulfillment, and self-compassion, part of the wellness. So, but not much focus has been done on a residency transition with regard to coaching impact. So there is definitely a need to address the stress of transition to residency. The AAMC in the summer of 2020 developed an executive summary based on the undergraduate medical education and the graduate medical education review committee that was charged with recommending solutions to identify the challenges faced during this transition. And there are a number of challenges. It's considered stressful, it's life-changing. There's concern for finding the right fit. How do they distinguish themselves among so many different candidates? And the number of applicants is going up across the country for residency. And what if they don't match? That also has implications that are stressful. And the goal is to decrease the stress, streamline the process, decrease the expense with platforms, policies, but also with support from the faculty at UME and GME level. So the American Medical Association also has determined this as an important issue, need to address the transition to residency. And they identified certain resources that could help during this transition that incorporate establishing a peer community, providing relocation resources, a curriculum for the transition with regard to EMR, policies, and how the program functions, training on medical racism and bias, cross-program connections. A lot of residents may be part of the medical school that's affiliated with the residency. Some are from many different parts of the country and may not know anyone as they start their residency. And it's important to help support them in feeling included and part of the team. And also another resource, and a very important one that this one sort of focuses on, is a check-in from program leadership. mentors, and coaching. As Alice mentioned, this is a new area that's developing a focus as a game changer during this transition.
It's very inconsistent now, coaching. It's not like a mandate, but it's surely respected.
Okay, thank you. And I think it's gaining some traction. There are some programs that have implemented transition to residency programs, some that have incorporated coaching, but as Alice mentioned, not all of them. So there's some transition to residency programs that can be seen as boot camps, new resident orientation programs. They're supported by the AAMC and APCO, or, there's a focus to support the transitions. So the goals of coaching residents, the goals cover many different areas: academic, clinical, and personal. They're individualized to each resident, and it provides a personalized curriculum to provide the scaffold for learning and advancement. So I'd like to open this up for a question. Andy, you have any input? The question is, as educators in a health system, especially ours, do you have any comments on these goals for coaching? I'm going to go back a slide just so you can see the goals.
Sure, Terry, thanks. I think in particular, because coaching is very much client driven, right? Or student or trainee driven. The goals, the expectations, the aspirations will depend upon where someone is in training. So if it's a transition to residency, for example, it's just getting your feet under you. How do I interact with people in this different role? If it's later on and you're a chief resident or senior resident, how do I be a leader of a team, right? How do I provide feedback? If it's that end of the year thing, it's how do I transition to practice? If it's a fellow, it may be how do I go from being a competent performer to trying to be an elite performer? And then there are different issues once one gets to being an attending. And there are always those other things of how do I balance work and life? How do I manage other things? How do I do my day job and look to the future? So I think coaching can be helpful, and that's why it's called a helping conversation at any point, but one size doesn't fit all. It really depends on where someone is in the trajectory of their career and what they're hoping to work on.
Thank you, Andy. Alice?
Thanks. No, definitely. And I wondered if the students had ever thought about this concept of coaching. I'm just wondering, since we have a few medical students on today. Anybody?
Yeah, I could share. A lot of when I think of coaching comes from being involved in athletics. And so
Definitely.
that's kind of my preconceived notion. But this to me is a good reminder of why it's so important to be self-motivated, right? If you don't have a motivated learner, coaching would strike me as something that wouldn't be super fruitful. And so I think it's, for someone to really get maximal benefit out of coaching, they've really got to be self-aware and self-motivated. At least that would
I
be
think
my
it
thought.
definitely.
Thank you,
You
Trevor.
caught on an important point of coaching, Trevor, that it comes from the individual. That's why advising is different. If I sit down with you as an advisor and tell you something, you could choose to listen to me or not, but coaching comes from the individual. Your connection to athletics is really athletics and theater and music, the arts have been doing coaching, of course, forever. It's more new to medicine, but it's not a new concept. It's been there. Andy?
Yeah, I would just add to that couple of quick things. One is that the analogy of coaching in sports to professional or executive coaching is similar, but it's not the same. It is a different dynamic, a different framework, different goals, different drivers. So it's similar. It's a helping relationship, but there's still a different kind of symmetry or asymmetry there. But it's a powerful thing to draw on in that kind of setting. And just to the point you made about being coached, I'll put an article in the chat from Atul Gawande called Personal Best. It's an old article. You may have read it. If you haven't, I recommend it. It talks about his thoughts on coaching. Again, it's a different kind of coaching than executive coaching, but it's the idea of it as doctors, we often stop getting support when we graduate, and most other performers, elite performers, get coached throughout their career, right? So it's a fun article. It's worth reading if you have the time. I'll put it in the chat.
That's fascinating. Thank you, Andy.
Oh, an oldie but goodie. So thank you, Andy. Go ahead, continue. I'm
Okay.
a little worried about time, so let's go.
Okay. So
Oh, good. We're up to the study.
we're up to the study, and this is why I chose this article to fill the need of the transition to residency with coaching. So this study objective focuses on the impact of coaching for residents in transition to residency. So the methods, the participants were PGY2 residents. Their survey was distributed halfway through the PGY2 year. The residents were part of a 4-year residency with 4 different specialties, including OBGYN, internal medicine, emergency medicine, and pathology. The coaching began on match day and extended until the end of the first year of residency. The coaching was at a single academic center in an urban setting at NYU. And NYU offered a Transition to Residency Advantage program, the TRA program, and it was supported by the AMA Reimagining the Transition to Residency. Sorry, so let me see. So the coaches are considered GME bridge coaches. They were involved in a faculty development program. So it wasn't that they were certified, but they did participate in a training. And the program began with the UME educational advisor, the undergraduate medical education advisor, the GME bridge coach, graduate medical education bridge coach, and the student meeting to initiate the coaching. Coaching meetings were quarterly. It was one-to-one coaching and some group coaching. It was in person and virtual. And let me see. They used a navigator program, which is a platform that sort of tracked the schedule and tracked the goals for the learner. Study design. It was a comparison cohort study. One cohort was the coached TRA program study, and the other one was the uncoached, which was the year before, prior. The survey was only post-coaching, post-test only. It was an anonymous survey online, and the assessment was to evaluate the effectiveness of coaching on these measures of self-directed learning, professional development, program support, and the impact of coaching. There were some confounding variables that they considered, such as gender, underrepresented in medicine students, the medical school where the medical students graduated, and the coping skills of each student. And it also focused on burnout. This survey was administered during the COVID pandemic. The uncoached cohort was at the start of the pandemic, and the coached cohort was during a surge with variants, COVID variants. So the students that were surveyed were the residents that were surveyed were PGY2 residents. There was a total of 156 residents, and who were asked to survey, and 86 residents completed the survey. And these were the scales that were used to interpret the data. Part of the survey, brief resilient coping scale, Connor-Davidson resilience scale, a burnout inventory, novel Maslach, and bivariate t-test, and chi-square, and MANOVA. So the data collection was based on a survey on a Likert scale, and the survey questions were obtained from all of these sources and some that they developed independently. So again, the background characteristics that were mentioned earlier, the brief resilient coping skill, the Maslach burnout inventory, goal setting, competing priorities, comfort and skills, 4 master adaptive learning habits and gaps, Connor-Davison resilience scale, Stanford professional fulfillment index, career self-efficacy, residency sea change survey mentoring, and residency sea change survey program support. I was curious to see the actual survey. I didn't see it at an addendum. Considering reaching out to the authors to see if they would share the survey. If anyone's interested, I could reach out. So the procedure and data analysis. So the pre-TRA, the transition to residency program, was administered November 2021 to January of 2022. And the cohort that benefited from the coaching was the following year. The recruitment was from the residency programs, a 20-minute introduction. The survey was introduced, informed consent was obtained. It was approved by the IRB. The survey was anonymous, and 6 follow-up emails were sent to complete the survey. And as mentioned, these were the data analysis tests, t-tests, chi-square tests, and MANOVA analysis for the burnout. So at this point, any thoughts on the methods, data collection, analysis?
So I have quite a few thoughts on this. First of all, it's very unusual that you do a study where you give half a group something in education and not give the other. So this is really breaking the mold a little of how we normally do things, because even though you do this with drug trials all the time and clinical trials, in medical education, depriving a group of something that we think is beneficial is not common. So I want to mention them setting that up, I thought was interesting. It does help to give you 2 perspectives, which is great. There's a lot of instruments here. So does anybody have any comments on that? And is there any qualitative data? I'm not clear. So anybody want to comment besides us?
Dr.
Dr.
Schlegel.
Menzin,
Oh,
yeah, but Dr. Schlegel, great. Go ahead. Hello, Dr. Schlegel, who's now living in Arkansas. Welcome back to the US.
Thank you very much. And I want to add that this is a super important topic, and the Alice Walton School of Medicine incorporates coaching actually in the curriculum as a core for developing our students in order to become physicians. So it's a really very new approach. So we recognize how important that is. But back to the methods, I wonder if these different instruments produce somewhat interfering outcomes. So in other words, one instrument by itself is kind of wholesome and complete. But if you have other ones that kind of touch upon it, if it might be hard to read and hard to really evaluate, then I find it is a problem if there's no pre and post. And obviously narrative, I would say this is definitely where you need a safe focus group or safe interviews in order to get more information.
thank you. So let me see. So
Before
delving
we
into
go
the
to, wait
response-
one
Oh, yeah.
second. Oh, I'm sorry. Before, any comments on the it's not a pre-post. Can you go back to the other slide, Teresa,
Yeah.
please? It's not
Oh,
pre-post
Yeah.
and it's anonymous.
Yes.
And
One is pre-intervention, one is post-intervention. but
There
a
was a
different
pre-post?
cohort.
No, can you go back a slide? You're on the results.
No, I know, it's not responding, I'm sorry.
Okay. Any thoughts on this study design? Why could you go over it again then? I thought it was all post.
It is all post, but I think the intervention, there was no intervention in the first cohort. And then there was the intervention for the second group of students the following year. So there are two different cohorts, different residents, different group, but one, and the survey was administered after coaching and in the PGY2 year. So one group didn't have any intervention, they just gave them their survey, and one was participated in the coaching. That's how I interpreted it.
I agree. It was two different time points, and that's part of the bias because it was overlapping the whole longitudinal COVID experience, which was a confounder, you know. But the first group had no coaching. They didn't know about coaching. It wasn't even on the radar. The second group was the intervention group.
Any other comments about this data collection? I mean, none of this is easy to do, so I'm not criticizing that it's easy, but certainly residents are really busy, and getting them to do surveys is certainly not easy. And when you do pre-post, just as education for our students, you could do a pre-post match, which is very difficult. And once again, anybody who does not do the pre can't do the post, and they do the post and they haven't done the pre, it's all that data is thrown out. So you can do aggregate pre-post, so aggregate pre and aggregate post, and that's what I tend to do in my education studies. So I have a pre-post, but I aggregate the data. I don't do a match pre-post, which is much more complicated. Beth, any comments on this? You're a researcher, recently granted her EDD.
Thank you, Alice. No, I think I think the thing that stuck out to me the most was just this idea, as you already mentioned, it's quite unusual in educational research to have a, quote unquote control group, right? Or that doesn't receive the treatment of whatever that is. So this is an unusual study in that respect to me. But
Yes.
I appreciate the discussion, and also in the comments, Dr. Schlegel sharing the incorporation of coaching in the curriculum, which I think is also so important. So
Thank you for those comments. So we're focusing now on results. So the participants, the no coaching cohort, 42 out of 78 completed the survey. So that's about 54%.
Not bad.
Yeah, half. And it's similar numbers for the coaching cohort, 44 out of 78. So 56% completed the survey. And on average, the number of coaching meetings per resident was 3.2. There is no significant difference noted regarding gender, underrepresented in medicine, students, local medical school, mean coping score, or mean burnout score, except the burnout significance in certain comments. And the TRA coaching cohort was 69%, 29. And in the coached cohort, the burnout was about 52%. And this was determined to be significantly less. Any comments? I have some charts to review. I'll advance the slide then.
Wait, go back.
I can go back. Oh, here we go.
You're being a typical physician and not giving people time to respond. So
here we go. I was able to go back and listening.
Good. Any comment on this number of coaching meetings? Andy, what do you think about this, considering the work we're doing with Harvard Macy? I think he had to leave.
All right,
Okay.
no, I'm on. Say again. in
The
relation.
the number of coaching meetings.
No, Terry and I were talking about this last night. You know, I think the interval is longer than I would plan, and what I would hope for. You know, typical coaching engagements have either an every 2 week or every 4 week interval. This is much bigger than that. You know, what I've tried to do with coaching our fellows and chief residents is set up a 1 month thing, because not everybody can make all of them. So hopefully you get as much as you can. You do the best you can, but this interval is not what I would consider optimal.
Right. Also, I'm just wondering, I think how many different disciplines were represented? It was EM, it was pathology, Terry.
Yes, it
and
was
with-
IM and OBGYN.
And pathology
Yes.
and EM. Yes.
Yes, EM, IM, and OBGYN and pathology. Yes. 4.
So is there any looking at the results based on based on that? So maybe you'll be showing us that, because to me, it's very 4 disparate residencies, I must say.
Agreed. Yeah, but overall, I think it was sort of balanced. And regarding the time frame, I want to mention that maybe the three meetings throughout a year could be more consistent with the mentorship type of schedule as opposed
Right.
to a coaching one. Okay, so I'm going to advance. So here is the representation of residents and residency programs. So here in the pre-coaching cohort, the number of internal medicine residents was 44, 23 completed the residency, which is a 52% response rate. And emergency medicine, it was a 50% response rate with
Similar.
a number of 9 residents. So a smaller number for emergency medicine. OBGYN, about 7 residents completed the survey, which is about 70% of the 10 that were part of the cohort. And pathology, the smallest cohort regarding specialty was 3 completed the survey, which is 50%. So I see. In response rate, they seem somewhat similar in the uncoached group, aside from OBGYN. But this doctor, I think the lead, Dr. Winkler, is an OBGYN. But the largest specialty with residents is internal medicine, followed by emergency medicine, then OBGYN, then pathology.
But I think it's interesting, the percentages for the others are similar, so that's good.
Yeah, for the coach group, it hovers around 50% for the most part, for a
Right.
total of 56% response rate.
Mhm.
And the demographics, they're fairly similar. There wasn't a significant difference. Let me see.
Okay.
Any questions regarding this? Okay, I'm going to advance the slide. So here are the MANOVA results for the main effective coaching, and the bolded variables are the ones that showed significant differences with the benefit regarding resilience, professional fulfillment, career self-efficacy, mentoring quality and amount of mentoring, program support for work-life balance, as Dr. Menzin mentioned, program support for career, and the goal setting seemed too hard, don't know how to set goals, or master adaptive learner habits. It wasn't considered a significant difference.
Which are all important in coaching.
Yes.
So that's interesting.
Mhm. And these were the burnout results. So there was a group that did not feel burnt out. And so the blue is the cohort that did not receive coaching. The orange bars, the cohort that did receive coaching. And when they're not burnt out, they did have comparable skills regarding professional fulfillment. If they were burnt out, the uncoached cohort did not have as much professional fulfillment. They were more negative or neutral regarding this variable. With regard to program support for their career, it's comparable when they're not burnt out, but when they're burnt out, there's a significantly more in the coaching group that had a positive response to program support for their career. Regarding goal setting too hard, uncoached is comparable when they're not burnt out, and when they are coached, it was pretty similar. But there was a more positive response with the coach group. So these are challenging skills, as Alice mentioned, but overall, coaching did make a difference in these.
I just want to ask the students what they think, and then Beth has her hand raised, but what the students think about this difficulty with goal setting, because that's a big part of coaching, that the individual sets goals. And as students, do you have any idea why that was such a struggle for these people?
I can kind of jump in here.
Go ahead, thanks.
I feel like as students, sometimes we see things pretty myopically. Like in my experience in the residency app cycle right now, before this app season, my focus was step 2. And before that, my focus was clerkships. And when you're kind of living like accomplishment to accomplishment or like setback to setback, it is hard to look really far ahead in terms of like career planning and leading to what causes fulfillment for you. And so I feel like that might be a struggle because every obstacle seems like a mission to surmount before you can get to the next one.
Right. That's really great perspective, Adam. I love that. I really find that very insightful. So the way we run medical education, having these inner goals, the goals are set for you. You need to do step 2. You need to get your application in. You need to go on interviews. You need to show up at match day, those type things, it's all set. So I think you're right. Maybe we don't, that's why coaching for medical students has to start early, and then it will be more natural in residency. Right now, coaching in medical school is also a new concept. I can't say it's not happening because there are certain places it is more than others. Beth, do you want to comment?
I just wanted to ask a clarifying question I might have missed. If it was the Maslach's burnout inventory, the full assessment that was shared, was that the tool, the instrument that was used?
I believe that was the instrument, but I don't know if they did the entire instrument survey.
Because sometimes we see when, measurements of burnout, there are a number of versions of Maslach's that are offered. Maslach's, of course, is a licensed thing, and it's a much more involved tool and assessment, which is great, measuring the 3 constructs of burnout, right? So emotional exhaustion, inefficacy, and cynicism, I think, right, are the 3 construct areas. And then there's also like the 1 question self-assessment, like, are you burned out? Are you not burned out? So I'm just curious if they drilled down to that level of, the 3 specific measurements in the 3 specific area of the constructs of burnout, because I think things like reduced sense of personal accomplishment could really correspond with some of these, other sort of topics that there could be some interesting linkages there. So it's just curious.
That's an excellent question. I'm trying to reference the article. I'm not certain. I think it might have been the last one you mentioned. Do you feel burned out? Do you not?
Right, that's the one. That's the 1 question one. Yeah, it's very commonly used. Yeah.
Right.
Elizabeth,
and so sometimes that can
go ahead.
include things that maybe we wouldn't necessarily see. So I'd love to just see a more fine-tuned version of this if I had a magic wand and could redesign, because sometimes we maybe, higher in or lower in sense of professional fulfillment or self-efficacy, but we might be, higher in emotional exhaustion. So there can be, trade-offs.
Yes. Thank you for sharing that, Beth. And Elizabeth?
Yeah, so I'm just amusing a little bit on goal setting being too hard. And at the Zucker School of Medicine, we had done research in students as teachers. And it had actually showed that students as teachers, students who are very active educators, were better prepared or seemed to have indicators of being better prepared for residency. And as an educator, you set goals and learning objectives all the time. And I wonder if that actually sets you up for being more receptive as a coachee. And it's really just a question, but I wonder if teaching and coach, it is related somewhere, right? You deal with goals, you deal with learning objectives. And I wonder if this is something that would also help students to, really embrace coaching. But I do understand it's hard. You go from accomplishment to accomplishment, and it's not easy at all. I get it.
Yes, and Adam described that concept very well. That's what characterizes the transition to residency. And that's how doctors are trained, the goal to goal to goal, we're achievers in that sense.
Really did. He did a great job at it.
Yes, thank you, Adam. Okay, may I advance?
Okay, you want to go on next?
Sure.
Yes, advance.
Oh. So here are the results of the burnout, I guess, detailed. Beth, I don't know if this answers your question.
No, this is the
This
one.
was the same slide.
These are the other surveys. Yeah, go ahead. You can go to the next one.
Okay, so this data is regarding the impact or their interactions with their coach on these variables or domains: clinical decision-making, clinical skill development, academic portfolio, professionalism, scholarship, research and publications, work-life balance, teamwork, career choice, career preparation and planning, personal fulfillment, wellness, resilience, personal development, professional fulfillment, incorporating goals into your lifelong learning and development, and being a self-directed learner. And the coach group had a more positive response to the majority of these domains.
So it's interesting. Let's just take a minute. So the top one was being a self-directed learner, I think, yeah, with incorporating goals into my lifelong learning and development, and then professional fulfillment. Clinical decision-making was the last. Okay, makes sense. Clinical skill development, yeah. Okay,
Well,
just at a time, you might want to go on. I think some of this is.
So here, yes. So this is the comparison. The coached cohort had less burnout, more positive associations with attitude, professional fulfillment, goal setting, perceived program support compared to the uncoached group. So we discussed some of these results. We can circle back. Limitations of the study, demographics, research design, as we touched upon during our discussion, the small sample size, small response rate, selection bias, are those that are less burnt out responding or had time to complete the survey, individual coping, and clinical environment regarding the COVID pandemic. Does anyone want to add something here?
That's good. It's all true.
Okay. So the coaching is seen as beneficial with regard to goal setting and lifelong learning, scaffold for individual professional development, resident well-being, effective support for residents experiencing burnout. And I do want to make a note that this was not performance-based coaching regarding direct observation on clinical experiences with feedback. That wasn't part of this study. It was more of the self-reflection and their experiences, clinical experiences, but it wasn't direct observation, which maybe that's why it impacted the clinical skill development. So takeaways, coaching is beneficial for medical students transitioning to residency and lifelong. And if anyone can share your takeaways, Andy, Alice, anyone else? Will open
Before we do that, just at a time, we can come back to the takeaways.
Okay, sure.
I will,
yeah.
but just go ahead one slide. please.
Okay,
Okay,
these are
there. No, go back. Terry, slow down, go back. Go ahead just to the bibliometrics. Go ahead, Leanna.
Here we
Thank
go.
you.
Yeah, hi. I'm Leanna Steger. I'm the scholarly publications librarian for both the Zucker School of Medicine and Northwell Health. And I'm going to talk a little bit about the bibliometrics for this month's article. These metrics are from Scopus and from the publisher's website. So it's actually gotten quite a bit of attention so far, despite what Alex said at the beginning. It's been cited 8 times.
That's why
which
you're
gives
a
it
librarian. I don't understand it. Go ahead.
Yeah, it's already been cited 8 times, which gives it a field-weighted citation impact value of 12.93. The field-weighted citation impact is a metric that shows how well a document has been cited compared to similar documents of a similar age. Anything above a 1.0 means the document has been cited more than expected, so 12.93 is pretty high. It's also been saved 21 times via the Mendeley Citation Manager, which kind of indicates that the person intends to go back and read or reread it and perhaps cite it in their own work. And from the publisher's website, it's already been downloaded 1,058 times.
Oh my God, so I really messed up. Thank you for correcting me, Leanna. This is really a highly looked at article, which makes sense since we're saying this is sort of an up and coming topic, even though the ACGME and the AMA and the AAMC are all talking about coaching. So I appreciate the total accurate report out. Thank you. Now we can go to takeaways before we just about to end. Go to the last slide also, please. And Leanna's going to put the eval in the chat, and you will get an email with a copy of the PowerPoint, unless I make a podcast where you'll get the podcast, but I haven't done that yet. And this is our next topic, which is illness scripts to foster clinical reasoning, another technique of teaching. And we have a great speaker who's very dedicated to the topic clinically, and we will have a discussant who is very dedicated to this topic as well, Ethan Freed. And please do the survey, and thank Terry for coming here and Andy for coming and spending the hour with us. Any takeaway from this? From my medical students, anyone?
Yeah, I can give one. I really enjoyed the difference in the nuances between mentorship, sponsorship, and while acknowledging that each are different, all of those are valuable in their own ways. So at least for me as a student, in this current season, right, how can I be looking at that in programs and teasing that apart? And then also, how can I seek that out, wherever I'm going and knowing exactly what it is I'm looking for in coaching.
I'm at this coaching conference today, and I'm meeting people and I'm joining their LinkedIn sites because sometime I might want to ask them to sponsor me for something. You don't have to know somebody quite that well to sponsor them. I mean, you don't want it to be a stranger, but still. So sponsorship, people forget about how important most people in an organization the size of Northwell, which is now 100,000 employees and 30 hospitals and I forget how many residents we have now. Without sponsorship, you're not going to be noticed. I don't know how else to say it. Terry's taking ahead. It's easy to get lost in the weeds. So that's important. Mentoring is important. Coaching is important. They're all important, and advising, of course.
And I would just add to that, there's certainly an opportunity and a gap of what we offer and what most places have. But if you know about it, as now you do, I would encourage you to proactively seek it out, ask questions. Just today, you have exposure to 2 people who are certified coaches. It's an opportunity because as you mentioned, each one of the helping conversations offers different but overlapping things. And it's a resource. Sometimes institutions have it. Sometimes you look outside of your institution for doing it independently, but it's valuable nonetheless.
At this conference today, I found out about a whole company that Northwell partners with that I had no idea. And because a Northwell person is here, when I met her in the parking lot, she said Alice, and I said her name. And I'm like, oh, we're here together. I thought I would know no one. And she was here on behalf of this company that we use at Northwell, which I had no idea that we use. So it's really interesting. There's a whole world out there. I'm with 500 people and hearing lots of stuff. So this is here to stay. This conference is focused, I just want to end with this, on AI being a hybrid method of coaching. And I went to an ethics session yesterday on the ethics of AI coaching. Very fascinating, the use of AI coaches. And anybody can access AI coaches. So that will be a whole new world to study and look at. So I'm going to end on that note. And
If I could just thank everyone for your time and your engagement, and a special thank you to Andy and Alice. Thank you so much for your coaching for today.